And there are 6-part series which came in BMJ in 2008. This is what I was referring to, that 3 key papers from this I had sent to my colleagues in the stroke guideline group. But starting from 2011, I think now nearly 30-part series have come in Journal of Clinical Epidemiology, which gives much more detail about grade methodology. And it keeps coming still, because there are areas of development in the field of diagnosis and prognosis which is going on. So I don't know why it gets stuck at times. Right. More than 110 organizations have adopted GRADE, and that includes World Health Organization and a very popular what you may say electronic textbook, which is up to date. So all the residents who have up to date in their mobile phone, they are actually, when they are reading, they are coming across this. Whether they really understand the nitty-gritty, I'm not sure, but at least they come across grading of evidence based on grade system. And most of the societies have accepted it. As I told you, even American Academy of Neurology uses this, though they don't accept explicitly that we are using grade system. So what are we grading? This grading system is very much mature for interventions. So I would suggest that when you are using interventions, that is the time when you should keep grade in mind, though it is being developed for diagnosis also and prognosis also. And this grades a body of evidence. Grade is not about grading individual studies. That is what you have to keep in mind, that individual studies are graded by different methods, including that we will come to risk of bias assessment. But grade is about body of evidence, which means accumulated body of evidence from various studies, usually a systematic review and meta-analysis, and not about individual studies. And more recently, as I said, it is being developed for prognosis and diagnosis, but I'm going to focus mainly on management or interventions. So there are, what are we grading? There are 2 components which are involved in this grading system. One is quality of the body of evidence. It's also called confidence, also called certainty in evidence, confidence in evidence. And there are 4 grades, high, moderate, low, and very low. There is nothing like very high. And I was discussing with Gordon Guyatt, if you made very low, then to be symmetrical, you should have had very high as well. So he says it is difficult to think that there will be anything like very high quality of evidence as much as we practice today. So therefore, it is better to have only 4 categories of evidence: high, moderate, low, and very low. And the second thing which we do is strength of recommendation. That is also graded, and there are strong recommendations and weak recommendations. That strong recommendations can be in favor or against. Weak recommendations can be in favor or against. WHO doesn't like to call any one of its recommendation as weak. So they use the word, and many other societies use the word conditional recommendation. I'm not sure how many people understand what we mean by conditional recommendation, but I proposed to the group that why don't we use optional recommendation, strong recommendation, optional recommendation. They still have not accepted it, but the words which are used are strong recommendations and weak or conditional recommendations. And this, the first part, which is certainty of evidence, as I told you, is talking about how much confidence we can have in the evidence, how certain we can be about the evidence which is available. It's not about how much is benefit, how much is risk. That will come when we are grading the strength of recommendation. We are only talking about whatever evidence we have, how much confident we can be about this, how much certain we can be about this. So is this certainty very low, moderate, or high? Before you start grading, first step is identify critical outcomes. And the grading is done outcome by outcome. Often people confuse this. It is not study by study. It is by outcome by outcome. So mortality, for example, may be studied in 5 papers. And there may be a systematic review and meta-analysis which combines all the evidence about mortality. Now, we are going to grade the evidence or certainty of evidence about mortality. That is the outcome. So we do outcome by outcome. In this example, which I have taken from the BMJ paper, is they are assessing what outcomes we are going to keep for phosphate-lowering drugs in patients with renal failure and hyperphosphatemia. And obviously, even though downside, which is unfavorable outcome like flatulence, may also be one of the outcomes assessed in the studies. Pain due to soft tissue calcification may also have been studied, but you don't think they are critical. So we have to classify outcomes into critical, important but not critical, and not important for decision making. And when we are saying critical, critical is for decision making. And I must say that surrogate outcomes, which are not clinical outcomes or clinical endpoints, are not considered critical. Critical outcomes are the ones which are clinical. And how do we define clinical? Clinical outcomes are those which tell us about how patients feels, functions, or survives. So anything related to survival is critical outcome. Even quality of life is maybe a critical outcome for certain things, or feelings of patients or functional ability of the patients are the critical outcome. And here, I must tell you that this classification of outcome is done by many groups in conjunction with the patients. So patient partners and caregiver partners are involved in grading the outcome. Which one do you think is critical for decision making? Now, each group can decide, each subsection can decide whether they want to involve patient partners or caregiver partners at this stage or not. But the classification has to be done. And when we do grading, we do only for critical outcomes. Even though other outcomes may be important for clinical decision making, it is not going to decide recommendation, and therefore we don't include them in the whole grading system. So when you prepare a grade profile, it will be outcome by outcome. So remember, it will be not study by study, by outcome. Now, when we start with 2 levels, high and low. Randomized controlled trials start high and observational studies start at low. Now, that doesn't mean randomized controlled trials will remain high. They may be downgraded to moderate, low, or even very low. So it is only the starting point. And this high and low will change on other factors. So there is some, can you mute please?
Yes, it's done.
Right. So my question to you will be, if RCTs start high, what could be the reasons for which they may be rated down to moderate, low, or very low? I would like at least 3-4 comments from you before I go further. Anybody can unmute and speak.
Sir, maybe the allocation or masking may not have been masked. It might not be blinded. So,
right.
We will look at the risk of bias.
Group may be heterogeneous.
Very good. So 2 points have come up. One is that there may be bias. This bias may creep in the studies. Even though they are randomized trials, the randomization may not be concealed, which will induce selection bias, or there may not be blinding. which will introduce measurement bias, and therefore, even though it is randomized controlled trials, it will be rated down. But if there are 5 trials, other very good point which you have said is, if the effects observed across the trials are heterogeneous, then heterogeneity lowers the level of confidence you may have. Though it is good to first explore what are the reasons for heterogeneity, but sometimes it happens that you don't find any explanation and heterogeneity remains to be explained. Even then you have to take a decision because you have to make recommendation. So when there is heterogeneity, even though all trials are randomized controlled trials, you will lower the level of evidence from high to moderate, low or very low. Any other point comes to your mind?
Even crossover.
Small effect sizes, clinically insignificant effect sizes.
Right. So the effect size, which is basically telling us about the quantity of effects or the magnitude of effect. Now that we will come to when we are making recommendation. Is the magnitude of benefit worth given the magnitude of risk or harm? That will come when we are moving from evidence to recommendation. So that is not magnitude of effect.
Not a determinant of confidence.
It's not a determinant of level of confidence. Any other point? There was something.
Sample size, sir? Sample size.
Sample size. Right. So if sample size is small, then obviously there will be very high level of uncertainty in whatever we get, because if you calculate confidence interval with a small sample size, it will be wide confidence interval, which may sometimes cross even the null value. So the benefit may be observed, but not certain because the confidence interval is not precise enough. Very good. So that is what is called a level of precision. Sample size gives us not only sample size, but also number of outcome events which you observe. It gives us level of precision. So lack of precision or imprecision is one of the reasons why randomized controlled trials can be lowered down in rating. Any other point?
When
Underpowered
primary
study.
outcomes are not clinical.
Say it again. When the outcomes are not clinical.
When the radiological outcomes are taken as a primary or like that.
Yeah. So good point. But just to tell you what I said 2 minutes ago, that we do the grading only for critical outcomes. So critical outcomes are the ones which are clinically important, patient important, sometimes called patient reported outcomes, patient important outcomes, so many terminologies goes. But these are the outcomes for which is going to determine the decision making. So I told you in the beginning that you decide which outcomes you are going to grade for. That is the critical outcomes, and therefore already radiological and other surrogate outcomes have been relegated to the background. We are only talking about critical outcomes. So that is not a reason for rating down because outcomes are already chosen to be critical.
Multi-centric versus from a single center, does it make any difference, sir?
So I can get a sense that multicentric studies will have some advantages because number one, there may be higher sample size, which will reflect in what I just now talked about, level of precision. So there will be high level of precision or less imprecision, and therefore perhaps better rating of evidence. But whether it is multicentric or single center, though there are other advantages of multicentric, but we are at this time rating the level of evidence of a cumulative all studies together. So yes, multicentric will come, but that will come or will be reflected in the level of precision, and if they have less bias, that will be also reflected in risk of bias. Very good points.
Underpowered study. Underpowered
bias due to
Underpowered study. Underpowered studies are small sample size or less number of events. which again comes into the level of precision. So yes, that is already there.
Significant dropouts. Significant dropouts.
Significant dropouts. So that is a lot of patients to start with, but randomized trial, as it progresses, number of patients, they are lost to follow up. That is what is called by Cochrane people as attrition bias. And yes, that is one of the components of risk of bias tool. So I'm very pleased that neurologists are bringing all the things which great people have thought. Before I go further, if there is any other comment, pressing comment, or I can go further. You have done.
Sir, kindly explain to me about the funding bias.
Yeah, that's what I was also about to suggest.
Right. So yes, I will come to that. So when we look at risk of bias, I think why don't we leave it at that at this time? There is another slide about risk of bias. Funding, who is funding the studies is a determinant of bias, and therefore bias is one of the determinant of rating of certainty of evidence. Good point.
So may I ask one thing, sir?
Yes,
sir,
yes.
In RCT, so RCT is now intention to treat versus per protocol. Like, sometimes there is they don't match, in that situation. How do you handle the
So yeah, the point is if studies have not done intention to treat analysis, they should be considered as perhaps having introduced bias in the analysis. So yes, bias in the analysis can also be one of the things, but good thing about determinants, or let's say the summary of evidence, is that when you do meta-analysis, if the studies have not done it, then you have to either ask the authors to give you data to do intention to treat analysis, or you can do some form of sensitivity analysis. So this is one of the component of risk of bias, but that can be corrected if there is a good meta-analysis. And also, if losses to follow up are reasons for lack of intention to treat analysis, then that is captured in attrition bias. Anyway, I think you did a very good point. So we had enough discussion, and you have already picked up some of the things. We randomize because we need prognostic balance, similarity of groups, similarity of prognostic factors across the two groups. So well-established things about good quality randomized trials is that there should be concealment of allocation. And you rightly said intention to treat principle should be observed, for which you need least number of loss to follow up, and there should be blinding. These are very well-established criteria for assessing whether there is risk of bias in the randomized trials. More recently, what is less perceived is selective outcome reporting bias. And that is, people write a protocol, register in clinicaltrials.gov or Indian Trial Registry or WHO Registry. But if you look at the outcome which they had talked about in the protocol, are not the outcomes which they analyze in the final paper. So that introduces bias. They only sometimes can you please mute if there are noises in your area? So there are studies which report only statistically significant findings, but don't report all the outcomes which they had planned to report. That introduces one kind of reporting bias. There can be another kind of reporting bias, which is if you choose a time point in your outcome assessment which suits you, because you have looked at patients up to 6 months, maybe 3 months, 6 months, 9 months, 1 year, but you choose only that time point where you find statistically significant finding, which will also be another kind of reporting bias. Stopping early for benefit. You already know that a lot of studies, they stop after interim analysis. And there have been several studies and papers which indicate that that leads to overestimation benefit, because you are stopping for benefit. Sometimes you stop for harm, in which case you are overestimating harm as well. But more often studies stop for benefit, which introduces a kind of inflation of benefit in those studies. And now, as you have rightly said, funding sources have also been recognized as one of the component introducing bias in the randomized trials. So that is the risk of bias is one of the important criteria. So when you do it, study, you take an outcome, you look at all the studies from this point of view. Of course, the study, if it is done properly, it will be good for all the outcomes. But some outcomes, for example, are not subject to blinding. You know, if mortality is the outcome, then if blinding was not there, you may still rate it as good study for mortality. But for another outcome, it may not be good because there is, you can say, subjectivity in the assessment of the outcome. So that is why it is done outcome by outcome. And then we look at all the studies together in a meta-analysis or systematic review. Now, let me digress a bit because I want this talk to be as light as possible. Some students complained to the dean that there has been a problem with the examination results. Some students who failed were actually good, and some students who passed were not good at all. Not unusual complaint. Those who have been heads of the departments or deans or directors, they know that the students often complain like this. So what does the poor dean do? He has a choice to cancel the exam or form a committee. So what does a dean usually do? Form a committee or cancel the exam?
Form a committee.
Form a committee, that's right. So dean appoints a committee to examine whether there is really a problem or not. And if there is a problem, then investigate the problem in detail. So how do you recognize whether there is a problem or not? So the committee, what the committee did was, it looked at all the papers, looked at the exam first. So the exam was like this: written exam, full marks 100, practical full marks 100, oral full marks 100, and pass marks was 50% of total overall. So what the committee did was, he first looked at the marks of every student across written, practical, and oral. And they started finding some, you can say, lack of similarity or different patterns, and they made 4 patterns. So each pattern is belongs to several students. And pattern 1, which was something like this, that students have written theory marks around 55, practical around 60, it may be 61, 62, 59, whatever, around 60. Oral was around 65. Overall total was around 60%, so they passed. 10 students were such that written exam score was around 15, but practical was 70 and oral was around 80. They also passed because overall it was around 55%. So that was second kind of pattern they found. Third pattern they found, which belonging to 20 students, was that written exam was around 40, practical around 45, Viva around 35. So they got around 40%, they failed. And fourth pattern was, the written was around 90, practical was around 20, oral around 25, they got 45%, so they also failed. My question to you is, has there been a problem or not?
Yes, sir. Pattern 2 and pattern 4.
Pattern 2 and pattern 4. So why did you say that pattern 1 doesn't have a problem? Anybody can answer.
Pattern 1 has got a more homogeneous distribution, we can say, like their written examination and practical is almost, we can say, they are performing on all the areas.
Pattern 2, why there is problem in pattern 2?
Though the written is 15, practical and oral, they are scoring too much, very high marks.
What could be the reasons?
That could be biases involved, sir.
Bias.
What bias?
Not necessarily, sir. Not necessarily, because we have two kinds of students. That, see, for example, one is purely very good verbally, but very poor at writing. There is other group of students who are very poor in, very good in writing things, but when it comes to practicality as well as expressing themselves, they are poor. So these are two kinds of students which we see.
So Dr. Lakshmi is saying that these are true findings without bias, but these are realities, and that is because of the different kinds of competence of the students.
Yes, yes, sir.
So I don't have a way to take a vote how many people agree with you, right? But any other explanation?
It is possible that in pattern 2, there is some favor shown by the people who are conducting the practical and oral because it's a cross disparity.
Right. When I do with the students or residents, this is the commonest answer I get, right? That these are because they were favored in practical and oral, easy to do that. And in another country, when I was showing this, they said, Dr. Prasad, this was, I think, in Egypt or somewhere. They said, these are professors' children. You see, so that's the same thing which you are talking about. Anyway, pattern 3, again, nobody says there is a problem. What is the problem in pattern 4?
So that's where the examiner possibly or the professor didn't like the students and gave them very low points.
Right.
That would also be a bias. I would call it a negative bias, but that could have been a bias too.
Yeah. So that is also a bias. Good point. And when I show this to the students, they, say that this happens with the student union leaders, because they have been troubling the HOD for a long time, and this is what they get in the exam. So it doesn't happen. When I was presenting in other country, I said, this doesn't happen in India. It may be happening in your country. But when I say this to students in India, they don't agree with me. So anyway, the point is that, yes, there could be bias in pattern 2 and pattern 5 and pattern 4. And you accept a pattern 1 and 3 because they are homogeneous. And that's a good word. That is what I would also think. And similar marks, which is across all the evaluations, is homogeneity. When there is dissimilarity, we call it heterogeneity. So this has a relevance in meta-analysis also, because meta-analysis is doing nothing, but each study has evaluated the same treatment, roughly, and we are going to take out average from these 2 or more treatment. So we will accept it if there is homogeneity. If there is heterogeneity, then there may be bias in the study. That may be one reason for this. There may be many other reasons. I'm not going into the details, but certainly it is a problem. So a combined results is easily accepted, and you can say given credibility if there is homogeneity. If there is heterogeneity, then you need to investigate the heterogeneity. Maybe younger and older people have responded differently, so you may do subgroup analysis, or maybe good quality studies are showing less effect than the poor quality studies. Then you want to do again separate analysis of good and poor quality studies. If you don't find any explanation in spite of everything which you try to do, then at least one thing you can do is that you can downgrade the level of certainty of the evidence or quality level of the evidence. So that is why heterogeneity, one of the reasons why it is downloaded. So you can see if this was the kind of meta-analysis you are looking at, nobody will have any problem in accepting this, and there is absolute homogeneity. This will be accepted as it is. But if this is the kind of studies you see where 2 studies are actually showing going in favor, 2 studies are going against. Yet people have taken out an average. Obviously, this is heterogeneity, and such meta-analysis or for any outcome, for example, will be lowered down in the certainty of evidence or quality of evidence. So how do we look at this? We look at the point estimates. So if you look down the red color, which you think are called point estimates, and the lines are confidence intervals. So in the previous study, we all agreed there is homogeneity. All the red squares, which are point estimates, are very close to each other. And the confidence intervals, which is the lines which are overlapping. So there is no confusion about homogeneity. Here, both the things are not happening. Point estimates, which are red color squares, are divergent, and the confidence intervals are not overlapping. So when we look at homogeneity, then we look at point estimates, whether they are similar or not, whether confidence intervals are overlapping or not. So here you can see some people often say that when all the point estimates are one side of the line of no difference, then we say it is homogeneous. No, that's not true. Here you can see they are on the 2 different lines, but they are very close to each other. So even this is also homogeneous. And how do we measure it? These days, more popular than chi-square test is I-square. And I-square is perhaps standing for inconsistency square, or the degree of variability across the studies, which is because of true variability. And that is why you see that it can be 100% or it can be 0%. So I think one of the things which we have to do is to look at the I-square of the meta-analysis, which you are going to look at, and see whether there is heterogeneity. Beyond 50% is not acceptable, but below that also there may be sometimes problems, and that's why you also look at point estimates and confidence intervals. So here, of course, I-square will be p-value will be 0.99, I-square will be 0, and here it will be I-square will be 89%, and p-value for heterogeneity will be less than 0.001. So when there is heterogeneity, then one must look for explanation, whether it is because of different patients responding differently, whether the intervention in one is a low dose versus a small dose, or oral versus intravenous, or the outcomes which are measured are different, and maybe even timing of measurement of outcomes may be short term versus long term, or there may be risk of bias, like we talked about the students' scores, the risk of bias. So if there is no good explanation, then at least decrease the confidence level on the effect estimates. I must tell you one thing is that this story about students I presented in one of the research meeting of the World Stroke Organization conference, and Vladimir Hachinsky was chairing that meeting, and then he was also listening. So at the end, he got up and asked, Dr. Prasad, you didn't tell us what happened to the students. So I told him that, look here, this is hypothetical example. This is not a real example. So you can imagine how much he was concerned about the students if it happened in reality. Now that is about heterogeneity. One of the reasons for down rating the evidence is heterogeneity. The other reason is imprecision. So some of you have already said that small sample sizes, small number of events, if it is dichotomous outcome, then these are going to lower down the quality of evidence. Or wide confidence intervals, that is also a kind of expression of the lack of precision. And the question about how do you decide whether it is too wide or acceptable? Now that depends on certain factors. So for example, let's take atrial fibrillation and risk of stroke. We know that anticoagulant increases the serious risk of serious GI bleeding by 3% per year. Now, if 1,000 patients are treated with anticoagulation and one less stroke happens, obviously you will have 30 more bleeds. Now, will people accept it? No, they will not accept it. On the other hand, if there is 1,000 patients and 100 less strokes, even if we have 30 more bleeds, we will have almost 3 strokes prevented, more than 3, in fact, at least 3 strokes prevented out of each bleed. So this will be acceptable to anyone. The question is, between first and second, between 1,000 patients having 1 less stroke and 1,000 patients having 100 less strokes, where is the threshold? Where is the borderline? Where is the margin where you change your perception from acceptable to unacceptable? So in other words, how many strokes need to be prevented in 100 people, given that there is 3% risk of bleeding? So you may say that, well, 1% is our threshold. So the confidence interval, which is not crossing this threshold, is clearly precise enough, because minimum effect it will have is still more than 1%. Here it is not precise enough, even though it is on the same side of the line of no difference, because our threshold is getting crossed. Here also it is not precise enough, because it doesn't even reach the threshold. And of course, so all kinds of lack of precision can be there. And if you find that the minimal or the lower end of confidence interval is beyond the level of threshold, then only you can say that, yes, it is precise enough. So that is about level of precision. So any question about this? I have some stories around this, but I'm not going to tell due to lack of time. Otherwise, it would have been more clear. But any question about precision? No. So that is another. Now there is slightly different concept called directness. So if there is indirectness, then we lower down the quality of evidence. Now, what is directness versus indirectness? Now, directness, if a study is conducted in India, it is in Indian population, and the same kind of population where you are going to use the treatment, then it is direct evidence. You have direct evidence from your population where you are going to apply the guideline. On the other hand, if you have, let's say, studies which are done in older people, or and you want to use it for younger people, like in TB meningitis, most of the studies are in adults for dexamethasone, but you want to use also in children. So steroids in children with TB meningitis will be something like indirect evidence, though there are now papers which are quite reasonable number in children as well. So that the indirectness will be when different populations have been studied in the studies under consideration or the systematic review under consideration, but you are going to have a guideline for different populations. It can be intervention where it can be indirect as well. I will come to that example later on. And many people have said this and written papers about this, that what we see in trials about warfarin is not what happens in clinical practice. We face this every day in India, that people are taking warfarin, but jolly well not doing any INR for months together, and therefore land up with more complications than benefit. They also stop sometimes, or many a times, and therefore also don't get the benefit. So warfarin, how it fares in the trials is not going to fare so well in the population. Similarly, we may use the American dose of apixaban, which is 150 milligram twice a day, but you will get, you have no way to get the antibodies if there is a bleeding to counteract this. So this is dabigatran, sorry, not apixaban, dabigatran. So we have our own circumstances. So Different interventions may have been tested in trials, but in clinical practice for the guideline, it will be different. It may be different comparator to which it has been done. I'll come to that in another example. Or it may be different outcomes for which the studies have been done, but we are looking for different outcomes. Like studies may have been done on surrogate outcome, we are looking for important outcomes. Another way of indirectness is, suppose aspirin has been compared to placebo, clopidogrel has been compared to placebo, but then you want to have a recommendation whether to choose aspirin or clopidogrel. This is not the reality. The real example is that aspirin plus dipyridamole, as you know, ESPS 2 trial, was compared to aspirin alone, and Capri trial compared clopidogrel to aspirin. But then by just looking at these two studies, an indirect comparison between clopidogrel and dipyridamole aspirin combination, people started saying that dipyridamole aspirin is superior to clopidogrel. But when there is a direct trial was done, head-to-head comparison, both turned out to be very similar. So if you didn't have the direct evidence and you are going to make a trial, make a recommendation in a guideline whether to use aspirin dipyridamole combination or clopidogrel, you have only indirect evidence, not direct evidence. So these are the different types of indirectness. And so if there is indirectness, you have to rate down the quality of evidence. Next is publication bias. Publication bias, when you see that there are only small studies and number is small, very often when they are industry sponsored, then there is publication bias, and therefore we should rate down the evidence. I'm not going to go through the story in detail because it will take time, but just to tell you that you do that by looking at funnel plot. And the funnel plot, if it is symmetrical, then publication bias is very unlikely. Like these are all the studies. This is a plot of magnitude of effect size against precision of estimate of treatment effect. So it may be odds ratio here, and there may be confidence interval there, or sample size on this side in the y-axis. So when you plot it, then you find that there is symmetry, and then you will say, yes, there is no publication bias. On the other hand, if it is something like this, where you find that some trials which favor control rather than intervention are missing from the funnel plot, that means there is probably publication bias. So if publication bias is likely, then you have to rate down the quality of evidence. Now here you see streptokinase myocardial infarction meta-analysis was something like this, quite symmetrical. And when a large trial was done, ISIS-2, it almost confirmed the same finding. Similarly, nitrates in myocardial infarction, a large trial confirmed the findings of a meta-analysis. So when there is no publication bias, you have more confidence. So these are the 5 things which can rate down the quality of evidence. What did we say? The risk of bias is 1. Publication bias, which I just talked about. So 2 biases and 3 I's: indirectness, imprecision, or inconsistency. So any one of these 5 can rate down the quality of the evidence. What can raise the quality or certainty of evidence? Large magnitude. If it is, let's say, 50% reduction of adverse or unfavorable outcome, or twice increase of favorable outcome, that is a large magnitude. There may be somewhere there is 80% reduction in unfavorable outcome, 3 times increase in beneficial outcome, then it's a very high magnitude and therefore very large, and you may upgrade the level of evidence by 2 levels. So remember, even though observational studies start at low, they can go to 2 level up if there is very large magnitude. So it may become high quality evidence, even though they are from observational studies. Example will be, if there is a disease where everyone does badly and you come up with a treatment where almost everyone does well, Obviously, you don't need a randomized trial to have high quality evidence. For example, in Creutzfeldt-Jakob disease or in rabies, somebody comes with a new treatment where everyone starts recovering. Don't need randomized trial to say that it is a high level of evidence. So this is a summary of what happens in certainty of evidence. You look at, you start with randomized trials as high, observational studies as low. Then you lower randomized trial if there is risk of bias, inconsistency, indirectness, imprecision, or publication bias. Even if it is observational studies, you may increase the level of confidence or certainty. If there is a large effect, dose response is another one which you have to keep in mind. If there is dose response, you can increase the level of evidence by one level. And there is third criteria, little less intuitive. If all plausible confounding works in one direction and introduces bias in demonstrating effect against the intervention, then also you have to give, you have to give or rate the quality of evidence as higher. And if it is the other way around, you may rate it lower. So ultimately, final level of confidence rating will be high. So even if there is a randomized trial and shows dose response gradient, it doesn't become very high. Remember, there is nothing like very high. It remains at high. Or if a randomized trial is lowered down by one level, it becomes moderate. Or if observational studies doesn't get increased, it remains low. Or even randomized trial can be downgraded by 2 points, become low, or 3 points, becomes very low. But whatever are the reasons for upgrading or downgrading, you have to write it when you write a table like this. So this is a kind of table you have to keep in mind when you are doing this: high, moderate, low, very low. Of the randomized trials start high, observational studies start low. Now, depending on the risk of bias, whether it is serious or very serious, they will be downgraded by 1 or 2. Inconsistency, serious or very serious, downgraded by 1 or 2. Similarly, for indirectness, imprecision, and publication bias, it will be upgraded if there is large effect or very large effect, dose response, or plausible confounding working in one direction. And the grade table will look something like this. I told you grade table or grade evidence table looks outcome by outcome. So myocardial infarction, mortality, stroke, and then you look at how many number of participants. Within brackets, you write number of studies, then risk of bias, consistency, directness, precision, publication bias. And since these are not observational studies and there was no dose response or large magnitude, that did not come in the picture. Then summary of findings, overall quality of evidence, high, moderate, or low, or very low, then relative effect and absolute effect. So this is what, then strength of recommendation. There is a strong recommendation, benefits clearly outweigh the risks, hassle, and costs. But there can be good quality evidence, high certainty in evidence, but still downgraded recommendations. If there is so much, you can say, close balance between upside and downside, favorable effect and unfavorable effect, that you don't feel like it is worthwhile making strong recommendation. So I think strong recommendation means that do it. You don't have to be wishy-washy about this, but weak or conditional recommendations means probably do it, probably don't do it. How do you decide? You decide to some extent looking at the patient's circumstances and patient's preference. If it is strong recommendations, you can assume that almost all patients will make the same choice. If it is a weak or conditional recommendation, then choice will vary depending on whether the patient is a risk taker or risk averter. So a strong or weak recommendation gives you idea when to discuss with the patient in detail or when you just inform the patient and use it. Some organizations use decision aid when actually if there is strong recommendation, there is no need for it. But if there is weak recommendation, then yes, decision aids are useful. Strong and weak also gives accreditation bodies quality of care criterion. They always keep only strongly recommended interventions as something to check quality of care in hospitals. If you want to do it in your own hospital setting or unit, you want to use some criterion, then better use only those criteria where there is strong recommendation. There is also implication of values and preferences, and I will make that clear with some example. You know that some guidelines, they give grade 2B, or let's say Clopidogrel is superior to aspirin, and that means the recommendation to use Clopidogrel over aspirin places a relatively high value on small absolute risk reduction, which you get in stroke, and relatively low value on expenditure or cost of the drug. So Americans often they recommend Clopidogrel over aspirin. Canadians, they prefer aspirin over Clopidogrel, and that happened for some time in their guidelines as well across the border. US and Canada had different guidelines. That is because values of and preferences of people, both patients as well as guideline developers, were different because they didn't bother about cost. They placed high value on a small absolute risk reduction, which is better in Clopidogrel. So on the other hand, in peripheral vascular disease, aspirin is used in preference to Clopidogrel because they think it is not worthwhile spending so much money on Clopidogrel for very small reduction, which we see in vascular events. So to conclude, I think rating quality of evidence and strength of recommendation is essential now, as I will tell in the second part, for all guidelines. And grade system is the one which is most popular and is probably more transparent and very widely used. It is becoming worldwide standard, and therefore I will recommend that all the subsections use it. This is not a mandate, but I think Indian Academy of Neurology Executive Committee has strongly recommended that we use it. So that's part one. If there are any questions, I'll be happy to answer. Otherwise, I will proceed to the second part, how to proceed. What are the next steps?
Sir, in assessing the importance, can we use Delphi, sir?
Right. To assess which outcome is important, or you are talking about
outcome important?
Outcome. Yes. In assessing which outcome is critical, there are various methodologies which people use. And as I said, the input of patients, partners, and caregiver partners is considered important for deciding which outcomes are clinically important or critical for decision making. So, so you can certainly use that, but Delphi technique is mainly to make decision across specialists. Specialists often differ in many things, but I'm sure, but patients can also.
Because why I ask this question is, for example, each subsection they contain a lot of specialists. So each will have to come at a consensus of the various things. You should have something. Which of the outcome is going to be important, and which is going to, as you graded you beautifully shown on that flatulence and the death, the two extremes.
Yes.
So, so I need you to, for the policy of the Indian Academy of Neurology, of which would be which you suggest as
Delphi process may have many rounds, one round, second round, sometimes third round is also required. So it is something which consumes time. If people can do it and document it, itself will be contribution.
Yeah,
But
and I think we should do to international standards so that we can look at 22 papers across IAN of various subsections of international standard, like what European Society or what American Academy or what each academy does. Under your leadership, I'm sure that we will get. But only thing is, I think we should set a time frame for submission of all this, and we'll form a one committee one central committee will also look at the process and clears that process before submission for the academy, sir. That would be my humble suggestion.
that I will come to in the how to proceed.
Sure, sir. Thank you.
Any question about? I've covered in 1 hour what is covered in 3 days, and I told you at least there are 50 papers on this issue. But
an excellent talk, sir. Sir, I always I'm a fan of you. It's a very excellent talk and very, very short and crisp. Thank you.
Thank you very much. But any question for clarification?
Sir, one question.
Comment.
Dr. Gagan, please go ahead.
Yeah. So I think that was a wonderful exposition, absolutely, and made in such a short time made everything so clear. I just want to emphasize what Dr. Prasad has already been emphasizing. The methodological rigor is extremely important, and I think in anticipation of the second part of the talk, would that be today only, or?
Yeah, it will be today only. It's up to 1 o'clock.
So I think in terms of, I think it's extremely important. The grade methodology is different from certain other methods, but it is fairly simple. And if you would, sir, clarify again, what is the difference between strength of recommendation and the other? So how do we go about, differentiating between the two,
Yeah. So, just to repeat the question for those who may not have heard, the question is, there are criteria for grading evidence and then criteria for grading recommendation. As we said, high, low, moderate, high, moderate, low, very low is the certainty of evidence, and strong and weak are recommendations. What is the difference between the two? Right. If highly certain evidence is always a strong recommendation, there is no need to have two categories here and there. So the reason for difference is, one is looking at certainty of evidence or quality of evidence. But as I said, sometimes quality of evidence may be poor, but recommendation made by the experts may be strong. So for example, if one example which comes to my mind is in cysticercosis, particularly if there is calcification and patient had been free of seizures for 3 years, if I remember correctly, the committee wanted to make a strong recommendation that there is certainly no role for cysticidal therapy. And they looked at quality of evidence, very poor, because nobody has done a trial on such patients. So even though quality of evidence was poor, there was consensus that we should make a strong recommendation. So that was based on, you can say, in this case, consensus among the experts. On the other hand, between evidence to recommendations, there are various considerations. I have not covered this. I will cover this next time because there are 12 points which is considered in grade. But to summarize, 4 quick points are: level or certainty of evidence is only one. The second one which they see is, what is the resources? Will our country people be able to afford this medicine? Even though there is strong evidence, can we make a strong recommendation given that we have limited resources? So that is one consideration. consideration. Second consideration is, as I said, values and preferences. If most of the patients, in the outcome which we are talking about, don't value very highly, or on the other hand, they think, oh, okay, bleeding is okay, I will take blood transfusion, but still I want that we must have the best medicine and to prevent a stroke. That means they are undervaluing complications like bleeding compared to the benefit, which is prevention of stroke. That is, if right thing and its consensus is there, even though you may have close balance between this benefit and risk, you may still make a strong recommendation. So what is the balance between how much benefit, how much risk, how much is the cost, what resources are available, and of course, certainty of evidence is one factor. So there are several considerations when you move from evidence to recommendation, and high certainty evidence may sometimes lead to weak recommendation, and even low certainty evidence may lead to strong recommendation. This was specifically designed to allow experts to make sometimes strong recommendation if there is good reasons, even low certainty of evidence. So that dichotomy has been made by design so that it allows other considerations to come up, like cost effectiveness, economic analysis, and so on. But I will come to that later on, because evidence to decision, there are 12 different considerations in grade system. And that will be a different talk at some different stage. At this time, if we come up to the level of certainty of evidence, it will be good. Does that answer your question, Dr. Gagandev?
Yes, thank you very well. Thank you so much.
Sir, can I just have one question, small, short question? Thank you, sir, for that excellent, crisp talk and explaining to us in great detail about great recommendations. I just have a short question. Many times we may discuss strong and weak recommendations, but when we read quite a few of the recommendations, there'll always be a subtle recommendation which will state that this goes on the discretion of the physician to take the final call on the recommendation. We may have something which may have some with the wordings are very, I would say, not very crisp, and the recommendation would state this may be useful, may be harmful, and the final decision is with the physician. So that kind of is, I would like to know some clarity when we are going to write our recommendations. Do we use strong and weak as a kind of a dichotomized recommendation, or can we go ahead with this vague recommendation?
We can decide this is a good opportunity. IAN can make its own terminology. Strong, of course, nobody objects. Weak, many people object, because as WHO itself says, we don't make weak recommendation. We are such a big organization. So we call the recommendation conditional. Other alternative terms which have been suggested is discretionary recommendation. I have suggested optional recommendation, right? So people can exercise options. Some physicians may use it, some physicians may not use it, some patients may accept it, some patients may not accept it. So these terminologies are there. You are absolutely right that when the recommendation is conditional or discretionary or weak, then decision making is difficult. And physicians have to take a call. And as we have to be culturally sensitive, in some situations, we have to make sure whether we are reflecting patients' values and preferences when we are making decision. And sometimes it's good to engage in discussion with the patient to make a decision. So yes, strong, less discussion is required. But there is, if the evidence is not strong, or for some reason recommendation is weak, conditional, discretionary, or optional, then yes, there is burden on the physician to decide, reflecting, of course, what will be in the best interest of the patient, maybe sometimes after discussing with the patient.
Sure. So just one short additional question is about the choice of the member from the patient side, caregiver, and as well as the patient himself as a patient. Is there a way to choose the right member from the patient? Because there are some patients who would be very who would have a strong opinion and would possibly say yes, other doctor says. So how do we choose the right kind of a member? I do agree that most of the sign as well as the grade and or most international recommendations, they have patient groups. They have patient groups actually. They are representative from the group. So how do we choose in our case?
Right. It's not easy. First thing is there is no straight answer that this is how we do it. You are absolutely right. Some patients may be articulate, but also very strong, very opinionated and very strongly advocating one line of action or something. But the way to, in this case, of course, some guideline developers have conducted studies on patients to reflect wider opinion about patients and partners. And they have published also that what are the values and preferences of patients in particular recommendation or particular intervention when it is coming to recommendation. So they do a real survey of the patients. So that takes time. So what is the way out? Like you have to know your patients and make sure that somebody who can, there is a training involved in involving the patients. So you our TIA guideline, we had a patient trainer. So what we did was she contacted some patients, some caregivers, interacted with them, and then looked at those who are articulate at the best and at the same time, not very highly opinionated. And then she selected a few and gave training to them that, look here, we are going to discuss with you at some stage, what is the evidence, what is the balance of benefit and harm, and take your opinion also when making recommendation. So to understand this, this is what we are talking about. This is what very briefly she also described what is meta-analysis, how it is the forest plot, what does it mean. So some training of the patients was required. Now, how much our subsection will be able to do it, I'm not sure, but it is an ideal thing which we should strive. And you have to select patients so that they are not strongly biased in favor of one thing or the other.
Yeah, may I suggest here something?
Yes.
Dr. Kameshwar Prasad. See, there are certain support groups which are very, very active. I know that. Like
Yes.
MS Society is very active. The Epilepsy Society is very active. Stroke, there are a couple of guys active. So if the support group is being included in one of these study, and their secretary or chairperson is being asked that if you have reported something, or you like Alzheimer's disease, they are very, very active. So those support group which are very active, they can be incorporated along with the subsection who are involved in that subsection. Rest all as per your guidelines, you said we'll have to follow that. So I would suggest this.
Yeah, that's a good suggestion. Only thing is support group may have 200 members. So you have to select either based on their consensus, few. You can't have many people. I would recommend minimum 2 patients and 2 caregivers, not more than 4 or 5, because otherwise you will be outnumbered by the doctors, will be outnumbered by the patients. So this will be another kind of skew which will be.
So you ask the secretary or president of support group to recommend the people from their support group.
Yeah, that's right. That's right.
Yeah, thank you, sir, for that wonderful talk. Sir. Yeah, sir. Regarding this, you told about that interventional studies and then the grade recommendations. So you would request us to the subgroups, the subsections to look at the interventional questions first, rather than going into diagnostic and prognostic things. because grade
Yes,
is not a
that
very
will
good
be
thing for
that
that.
will be more desirable, because as I told you, grade system for diagnosis and prognosis is still in development, not very mature. So I think in the first round, you see, if we succeed in incorporating, or let's say enthusing people to work on guideline from Indian Academy of Neurology, it will be an ongoing process. It will continue as something American Academy people do time and again. Every year they come with 2, 3, 4 guidelines. So, but in the beginning, I would suggest, you are right, that we should focus on intervention.
Okay, sir. Thank you.
Okay.
Dr. Prasad, quick question, please. You showed an excellent illustration of. Sometimes when we look at the meta-analysis results, you see some evidences coming strongly on one side, and the evidence from some other clinical trials on the other side, and equal numbers sometimes. The individual density of the meta-analysis results also very similarly weighing. And here, it's one thing is obviously you can say that there is a major heterogeneity, and the entire evidence on either side is weak. But one could also, if one could see a specific country or a specific group of people from those areas, the results are on one side, and from other side, the results are on the opposite side. Could we make some kind of any logical deductions possible, or it could be based on say value or preferences, etc.?
We will come to that when we come to nitty-gritty of assessing the guideline and assessing the systematic reviews. We will come to that. So, if you permit me, Rohit, you have any question? Or
so my one question, since I've been associated with you in the past also, and we've discussed some of these things. My only question is, sir, what is the real benefit when we say we want to include patients in this decision making? When it comes to real practice, they will say, "Doctor, आप वो करिए जो करना है."
ठीक है, I know.
So, I mean, I sometimes feel, is it a dilution of the responsibility of a physician to some extent that we want to incorporate them? Because how much we explain them, even we sitting here, sir, are not as learned as you are about these recommendations and grades, because that's not a routine with us in teaching and doing things. So, I mean, even if we involve the patients, and we know that most of the patients in most of these guidelines that we're developing are going to be, we are going to pick up educated people who understand, who, as you said, are articulate. They will understand, but they may have a run-in phase, and they may eventually just loop around what we finally decide. So that's my only concern, sir. I mean, I'm asking you because you had this experience with the BMJ group, so that's why I wanted to.
I was surprised, I must tell you, that when I was doing this, we had discussed how to start. Patients were also, patient caregivers, they were there. So after we presented the evidence which is there, then decision making came about recommendation. We had decided that we will first ask the patients and caregivers before the doctors come in the picture, right? So we started asking the patients, and you will not believe that by the time we finished patients and caregivers, decision was done. There was no doctor who actually differed from what they had suggested. So I was surprised that actually they were making decisions in a very smart way, because I think we had, of course, selected patients, articulate as well as educated. But we didn't have to take any doctor's opinion on that. I can tell you that.
But sir, their population is very different. Those people are very decisive about what they want. They are decisive about their care. They are decisive about their outcomes. They are decisive about disability versus death. हमारी population बहुत अलग है sir.
हाँ तो ठीक है, तुम ट्राई करके देखो. The
No, we
reason
will definitely try. We should try. I agree, but
बता रहे हैं, when we were going to do stem cell trial ना, तो everybody said कि कोई कंसेंट देगा ही नहीं, सब तो बोलेंगे हमको स्टेम सेल दे दो. जब करने लग गए ना, तो there was no problem. Patients were willing to get to one arm or the other. So हम लोगों का कभी-कभी concept बड़ा ये रहता है, but I agree with you. I'm scared how it will be successful.
But sir, the only good thing I see is that if you give them a patient-based opinion, then largely we can tell that this is what patients thought about it. That's an advantage. That's what I.
Right. So let's try and involve them and let us see. This is a new thing which we are going to try. Okay, so I think let me go to the how to proceed thing, right? I think that is.
If you permit, Dr. Prasad, may I make a point? If you.
Yeah, please go ahead. Yes, please go ahead.
It will all depend on the type of disease we are handling. For example, if we do a study on TB meningitis or nutrition or malaria, your population will be entirely different compared to cirrhosis or Parkinson, or myasthenia, for example. You will have entirely different group of people who are articulate and willing to cooperate. We had a myasthenia group, and we have a professor who is very interested, and he's controlling everything and contributing in a positive way.
Yes.
So therefore, it is going to be very heterogeneous. It will be a new experiment for us to include these people in our decision making.
I agree with you. I agree with you. Give it a try.
Yeah.
And let us come up with whatever experience we get. Huh?
Sir, in fact, the illiterate people make decisions faster and give their opinion quicker. That's what we did one study in epilepsy, sir, where literate people took time. They said they'll go back, consult, come back, and all this. The illiterate people, they made the decision then and there, and then be done with that, sir. I always felt that we should try that.
Yes, let us try.
Yes.
So I have less than half an hour. I have to go quickly over this one, if you permit. You see, there is the reason I am saying this, you will get old definition in many textbooks, which was coined by Institute of Medicine in US, now called National Academy of Medicine, which is systematically developed statements to assist practitioner in patient decisions for appropriate healthcare decision. But new definition is statements that include recommendations intended to optimize patient care that are informed by a systematic review and an assessment of benefit and harm. So basically, systematic review now figures in the definition. This is what I wanted to say. This is different from care pathway and protocols. So I'm not going to spend time on distinguishing between them. Just a little bit of history that actually it started with cervical cancer. And now, of course, we have for everything. I'm not going to spend too much time on this. I have already sent this handbook to everyone. This is freely downloadable. Anybody wants to download it can do it. Institute of Medicine, which is now called National Academy of Medicine in the US, has had two books or guidance books. One came in 2006 or so, 2005 or 6. Then another one, most recent one, is 2011. And basically, they all follow the same thing. US Preventive Task Force also has standard for guideline development. We will come to this again. NICE also has developed guidelines. So every organization has it. European Stroke Organization has guidelines, and SOP, they call it Standard Operating Procedure. But Guidelines International, they are a network, Guidelines International Network. They have come up with an instrument called AGREE, and it has a second version which has come now. The point which is important to know is that these are the key components of high quality guidelines. One, of course, you have already developed or have a guideline development group. In each group, you have to decide about decision-making process. Will it be by vote? Will it be consensus? and you must have a chairperson and vice chairperson in each subsection guideline group. And you have to decide whether chairperson will vote in what circumstances. The other very important step is conflicts of interest. You will see that every guideline has now made it mandatory to have conflicts of interest statements signed by all the guideline group members. Then you have to decide about scope of the guideline, how far, how deep you want to go. Then methodology, then conduct evidence reviews, then come to guideline recommendation and rating of evidence and recommendation. There has to be peer review and stakeholder consultation. So I must tell you that stroke guideline, which we developed with Government of India, we had two major stakeholder consultation with district hospital doctors, medical college experts, and that is the kind of thing we have to look forward to. There has to be updating of guideline time to time, and of course, financial support and sponsoring organization has to be identified. This somebody who actually looked at all the books, handbooks which are there, basically said that all require a multidisciplinary panel. What do I mean by that? I will come to that later. They all talk about consumer involvement. You remember we had discussion about patients' involvement. Then they all identify the clinical questions or problems. I will also come to which questions and problems are priority. Then systematically review and appraise the literature, and then come to drafting of recommendations, then external consultation and peer review, then updating. So they are basically all talking about same kind of steps. Now, which area you should take at, you have to decide, and some priorities I am going to come to later on. Then how are you going to convene and run guideline development group? Whether you will do systematic review or use systematic review already published, how will you assess those systematic reviews, how you will translate evidence to recommendation, and then external review and stakeholders consultation. So rating of evidence, I've already said, most people are using grades, so I'm not going to spend time on that. But just briefly, this WHO book classifies guidelines into various types, and three types which we have to keep in mind is one they call rapid advice guidelines. If there is an emergency like COVID we all had, we have to have quick recommendation or quick guideline, which takes 2 to 3 months anyway because of several steps which one has to go through. Now, this may not happen if there is adoption or adaptation of guideline, but if you are framing guideline, formulating guideline, it will take 2-3 months for rapid advice guideline, 6 to 9 months. If there are standard guidelines, which is the usual thing which comes out, usually focused on some aspects of a disease, like we are talking about treatment aspects, and maybe in treatment also we may select some particular area for focus. And there is something called full guidelines, which will be for complete coverage of a disease. For example, dengue, if you want guidelines for management of dengue, that will be covering everything from diagnosis to treatment. That will take 2 to 3 years. So obviously we are talking about somewhere in between, which is standard guidelines focused on some aspects. For focusing, we need what is called scoping procedure. Scoping procedure is given in the WHO handbook. Some part of it is applicable to us, and some are not applicable. Why we don't have to have a steering group. The guideline development group is the steering group for us. Each subsection chairperson and vice chairperson or convener is actually heading the steering group. Of course, you have to do search of literature for relevant data and existing systematic review, and also check for availability of guidelines. So if there are already guidelines, then you may not have to undertake the whole exercise of going through writing systematic review and then developing it. So that is one thing which is very much applicable to us. The WHO says that you can write a draft version based on what other guidelines are there. And then you develop it further, but it says what it says at the end: formulate draft Pico questions. Pico questions, I think all of you perhaps know, but some young people may have joined who doesn't know. Unlikely, but I will still say Pico stands for population, I for intervention, C for comparator, and O for outcome. So when we develop questions related to interventions, these 4 components have to be identified, and that is usually the starting point. So how do we proceed? I think we proceed by a quick check of available guidelines, then decide our questions. These are the 2 very important things which we need to do. And I would be thinking that most of you will be doing some degree of adaptation of available guidelines, which may be sometimes adoption. You don't need to go very far. You think it is applicable to our settings. It is cost effective. It has no such resource implications that we cannot use it. There is no reason why we cannot adopt. Then you may adopt that guideline. Now, if you are adopting a guideline and which is major part of the guideline, perhaps you need to take permission from those who have published it. But if you are taking 1 or 2 recommendations from the guideline, I don't think that that requires permission from the people who have published it. But more often than adoption, you will probably do adaptation. Adaptation, I will come to how to do adaptation, but adaptation can be of all parts or adaptation can be of some parts. Or sometimes you can develop a new statement. So I will give you an example. When we were making the stroke guideline, as far as antiplatelet was concerned, we almost adopted the recommendation which was there. On the other hand, when it came to anticoagulation, and particularly when we were talking about, I think, dabigatran 150 milligram BD versus 110 milligram BD, we adapted it to our setting because 150 milligram BD is better, means more effective, but more risk of bleeding. 110 milligram BD is as effective as warfarin, but less risk of bleeding. Since we know that antidote to this is not going to be available in our country for a long time, and also we know that 150 milligram BD adopted or recommended by Americans is based on their, you can say, strictness about following only superiority trials, and they don't accept non-inferiority trials very often. Certainly FDA does not accept it. That is why FDA did not approve 110 milligram BD dose of dabigatran. So we don't need to, our FDA doesn't do that. And therefore, we don't have to take extra risk of bleeding in circumstances where antibodies are not available. It is all right to have as much effect as warfarin and use it because there is less bleeding. So that is kind of adaptation of the American guideline. But for tenecteplase, there was no guideline anywhere in the world because it was only approved in India. So we had to develop our own guideline. We had to do our own systematic review. But I must tell you that after we did it, we wrote to up to date that your recommendation is not consistent with evidence, and they had to change their recommendation. So if you do a good systematic review, even world level guidelines will listen to it and change their recommendations. So up to date had to change it. So I mean, you can have in your own subsection this discussion about adoption, adaptation, and de novo development. Now, adaptation process also has certain steps. One which I was talking about, you define your clinical questions. What is your Pico? Then search for source guidelines. Then you have to assess the guidelines. How to assess the guidelines? I will come to that very quickly. And then after you have evaluated the quality and coherence of the source guidelines, then you can talk about adaptation of the recommendations. After you have done it, then of course there will be external review. and endorsement and implementation. So great people have also come up with guideline how to go about adaptation. It is slightly, I think, complex, more complex than other guidelines. There are at least 8-9 guidelines how to adapt guidelines. So adaptation process is not yet so crystal clear that everybody will use the same format. Like for making guidelines, most people use grade, but most people don't use grade recommendation of how to adapt guidelines. So keep that in mind. But first step is deciding clinical question. What must be included? This I have taken from the WHO book. I think there is a good point about listening to this. And I'm going to emphasize on 2 things most. Of course, you have to identify within the subgroup what are the key issues which are crucial, and that will determine how much work you are going to do. But I will say it again, do not try to include everything. And I have seen Dr. Rohit's email. I think autoimmune group has this consideration that they want to include everything. Resist the temptation to write a textbook. This is what the WHO guideline says. Concentrate on the interventions or policies where you think change in practice is desired. I'm not saying that standard things need not be written. If you are adopting some recommendations, it is okay to adopt few. But concentrate. Concentrate word is very important. Where you think practice needs to be changed, or areas where there is controversy, or you think some guideline which is there is not easily applicable to our settings. Those are the areas where we have to put in more time, more concentration. And these are the things which one has to identify in each subsection. Of course, also consider the feasibility of implementing the recommendation. And no need to go into those recommendations like we are talking about alemtuzumab or something, where we know it is not available and very unlikely that it will be widely implemented. Although some background information may be useful, try to avoid repeating standard information like epidemiology, pathology, pharmacology, and so on, because these are not chapters of books. These are just guidelines. So please avoid spending too much time and lines on that. Of course, if you want to, this is an area of controversy, and you want to resolve that in the guideline, then of course you can go into details of this. Now, coming to conflict of interest declaration. When I was doing this BMJ guideline, they had, I told you about, I think, 38 pages of conflict of interest declaration, which includes all of this. I'm not going to ask you to do this, but I will send, if you are interested, the WHO format, which is, I think, 2 pages or 3 pages, which is much easier to fill up, and every guideline member must fill up right in the beginning. So that is one thing each guideline, each subsection has to decide. But here, something which Indian Academy of Neurology also has to take a decision, but I think there will be no problem in implementing this, that everybody has to declare conflict of interest. Now, if you have identified your question, you have already discussed about how decision will be done within your group, then you have got a guideline also. And the question is whether to adapt it, adopt it. Then you have to assess that guideline. This is very important. And assessing the guideline, there are many instruments, but 2 are very important instruments, very good instruments. One is called NEETS, which is from National Guideline Clearinghouse, extent of adherence to trustworthy standards. And the other one is AGREE. AGREE is from the Guidelines International group, and this one is from the National Guideline Clearinghouse. So I will go through both very quickly. These are available online. You can download, read it. but I just want you to see what are they talking about. One, of course, is disclose guideline funding source. We have no funding except for maybe little money from IN, so we are going to declare that. Disclosure of financial conflicts of interest, I've already talked about that. So your guideline will be evaluated also like this. So if you, whether there was lowest adherence or highest adherence, and when you are evaluating guideline, please do this. Management of conflict of interest, I have already talked about, but one thing I would say is the chairs and co-chairs should not have conflict of interest. And if there are some members with conflict of interest, they should be in minority. And of course, funders should have no role in CPG development. Guideline development group composition. Now, as this needs group says, that multidisciplinary means you should have at least some methodological experts. Now, the question will be, how many methodological experts do we have, and how do we define a methodologist in our setup? I thought about it. If somebody has done masters in clinical epidemiology, I know when I was examining a candidate in Jipmar, Puducherry, and Dr. Sunil Narayan will tell me, I forget her name, Rajeshwari or some other name. She has done masters in clinical epidemiology. I know that she's a neurologist with this master. Dr.
We have included her in the group also.
What's her name? What's her name?
She's Rajeshwari Akhoram.
Rajeshwari, na?
Yeah, yes. Yeah. She's in the team actually. She's listening.
Oh, okay, right.
Including the stroke group, yes.
Yeah, I'm just pointing out few I know. Others may know more. In AIMS, Dr. Dipti has done masters in clinical epidemiology. So I'm just pointing out few people whom you can depend on as methodologists, and I would like that you keep them in your loop. If there is any such issue, it can be helped. I'm always there. If there is some need for consultation, I'm available for that. So that is one thing which is composition. Then, of course, we talked about methodological experts. We also talked about patient and public perspectives. So just to see what people say, the guideline development group sought views and perspectives, preference of patients, patient surrogate, patient advocate. So there is so much. Our country is different, but we have to just know what others are doing and at least check whether it is feasible here or not. Then, very important, use of systematic review of evidence. Look at the search strategy. It is important that at least 2 electronic databases must have been searched. There is another instrument for assessing systematic review called Amstar, which I will show very quickly. Of course, then you will look at whether systematic reviews have selected the studies, how did they synthesize the evidence, and of course, we talked about rating or grading the quality or strength of evidence. This should be there in the guideline which you are going to use. Benefits and harms of recommendations should have been provided, and evidence summary supporting the recommendations should be available either in the same document or a separate document. Rating the strength of recommendations is essential component of any good guideline, and specific and unambiguous articulation of recommendations, then external review and updating. So this is the needs instrument for assessing a guideline. Agree 2 is a very popular, I must say the most popular, because needs has come only few years ago. Agree has been there for some years. The first version was, I think, around 2010. And there are 16, there are many points which they look at, but not very difficult. So what is to be looked at? Objectives, questions in the guideline, population, group membership, we talked about target population, preferences and views, again, talking about involving patients, target users, they should be part of the group, or at least their perspective should be used, specialists, family physicians, and so on. Rigor of development is sometimes they say that you decide which one is your domain, which is of priority. And many people say priority domain is rigor of development. Then you look at domain 3 first before you go to other domains. What do you look at? You look at search methods, evidence selection criteria, strengths and limitations of the evidence, formulation of recommendations, consideration of benefits and harms, link between recommendations and strength of evidence, external review. So that is updating procedure. These are up to rigor of development. Then, of course, domain 4 is clarity of presentation. Domain 5 is applicability. So if you complete this, that agree instrument gives you good data, how good is the instrument. Which one you use, that is your decision. Each subsection can decide between needs and agree. The problem with agree is agree has about, I think, 6 or 7 tools. Now, agree tool instrument looks at the guidelines, but when it comes to rigor of development, it refers you to use another tool, which is called agree rex. So it is a bit confusing. Needs has combined everything. That is why I think it is probably going to be preferred, but it is your choice whether you want to use agree to or needs. Then to look at systematic review, there is another guideline. I'm not going to go into the details. Maybe some other time we will go through this if people think there is a need to explain some of this, which is called Amstar 2. There are 16 points to be seen in a systematic review. If you are going to use it, then look at it. And then, of course, you can decide what to use. At this time, I would suggest that you decide the scope of your guideline, make guideline development group, decide how you are going to make decisions within the group, and also pick up questions where you will concentrate, like particularly if there is a difference between some guideline and our country's resources or country's situation. Also, if there is controversy, then of course you should pick that up, because that is what we have to spend more time on. And then in some other talk, we will talk about de novo development of the guideline, starting from step 1 to the last step. But at this time, if we can do this much, write the Pico questions, decide about guideline group, get conflicts of interest formed from everyone, look for guidelines which are available, and start assessing them using either agree to or needs instrument. You will need Amstar also when you are assessing the guideline, because you will look at guideline, you may look at recommendation, you may look at evidence. So these 3 components have to be looked at when you are going to adopt or adapt a guideline. Thank you very much. If there are any questions, I'm happy to.
Prasad, yeah. Can I ask you one thing? Dr.
Yes.
Prasad? Yeah,
Yes.
Thanks for this excellent presentation. 2 quick questions.
Yes.
In the subsection, the groups which you are forming the guideline committee, can they get somebody expert from the outside the country?
Yes, yes. I don't see any problem in that. Yes, yes, of course.
Okay.
And particularly as I was reflecting on, we have very few people who are methodologically trained. So if there is input from outside the country, from my side, I think it will be welcome.
Okay. And the other thing is that when the guideline committee gives a their report, then it goes to a review committee. So review committee is actually what will be the composition and who will decide about the review committee of that?
So I think there are 2 kinds of reviews here. One is peer review for finalizing the guideline, and the second is peer review for. So Dr. Vinay Goyal has to decide the peer review process of a submitted guideline. And I think you and myself, we are also in the group to decide how they will be peer reviewed for publication, right?
Okay.
So publication, Dr. Vinay Goyal has told me without peer review, for publication, he is not going to publish it. So there will be a peer review process from the editor, which is just to look at the whole guideline to publish. Maybe they will like you to shorten it. Maybe they will like you to work in some area a little more. Maybe there will be some input from peer review, maybe within the country or even outside the country. I don't know. It hasn't been decided yet. We will talk about that when the guidelines start coming for publication.
So one question to Dr. Nirmal. See, Nirmal, you had earlier told about that this may be a recommendation to the government of or ministry. Or,
yes.
Okay. So these things, before it is published, is it to be reviewed by also, or at least, green signal from the ministry that these will be the part of a national guidelines or anything?
What I'm supposed to do is I shall write to the Ministry of Health and tell them that IN is, once I get all the topics, IN is going to write guidelines for following this neurological diseases. And we will ready to do amendment or changes if there is any suggestion or any thing come from the Ministry of Health.
So, one quick question, please. Even though this is a continuous process, there has to be some basic timeline. Which appears to be a very complex thing for me, because depending upon the number of topics people select and the complexity of the topics, different subgroups will need the different kinds of timelines. Or how do we go about the timelines?
So, Dr. Prasad, in this context, just one thing I want to mention that maybe we can prioritize only one topic per subsection, so that it starts the ball rolling, because it is most important to have one topic per subsection.
Yeah, I agree with you. This is what I was going to say, that please don't all topics together. Start with one topic, and I would give 6 months to 9 months. I don't know what Dr. Surya would like to say, but it should not be more than that. And at least one guideline coming from each subsection will be good enough, not to cover everything. But as I said, once this starts in a proper perspective, there need not be a gap of 10 years before we do it. We can go on doing on ongoing way, and every year there may be some guidelines which will be published, but we should be at least doing one guideline per subsection within 6 to 9 months. Do you agree, Dr.
Dr. Prasad, it is like this, that there are some subsection who have sent 3 or 4 guidelines to be made. Because there are subsection where there are more than 100 members, 150 members. If they formulate a group of 5 or 10 with different guidelines, what is the objection we have? It is the same people should not be involved in 2 or 3 guidelines, because then that will delay their thing. So if there are different group involved in the subsection in different guidelines, I think we should not have any objection, because different set of people are working and it will involve more number of people. We should give them a timeline that initial guidelines or framework should come at 3 months. We review at 3 months, so that at least at the end of the 6 months, we have a concrete thing come, because then that goes for peer review. So ultimately it is going to take 9 months to 1 year, but preliminary at 3 months, and then second should come by 6 months.
No,
what we can also,
I was going to propose, I agree with you. If there are, I said minimum 1 from each subsection, but if they can do more, nothing like it. But I would say that there should be monthly review. Otherwise, 3 months people will, they will work only in the 3rd month.
Correct.
So I would propose every month there will be a review meeting. Right?
Absolutely, I agree with you.
Do you know, may I submit a point that, this is a very serious matter. And first of all, we should decide about the topics or these questions to be asked. Don't make it mandatory for every committee to make one, because, there will be some sort of compulsion. if the academy promotes 2-3 guidelines, it's a big deal. It's not necessary that, a composition, a group of 30 people, because you require people who are interested, capable, and the right questions are asked. There's no point in committing too much and then not fulfilling. So I think, better would be that people should be encouraged and start working in that area. The committee should be constituted by the people who have shown interest in that area and have evidence to have worked in that area, and then the process will start. Because otherwise, there will be slipshod and, hasty things and under compulsion. So that, in my opinion, will not be a good idea. And one should be able to justify why do we need a guideline in this area. If this is just an adoption, probably it's not needed. So what new is needed from the subgroup, what really is a need of the people or the patients or the doctors on that area. So maybe some thinking on the questions. This may be reviewed by a group of people. You can decide which people will review it. And then, we may work, and I'm not in favor of putting any sort of pressure.
I agree with you.
Dr. Mishra, I would tell you that this is first time I have seen such a gel of interest among the IEN members. And I think we are in a phase, we are in a transition phase where we are finding that more...
No, please don't misunderstand me. I'm not against...
Parthare wants to say something. Dr. Parthare?
Yes, sir. Thank you. Thank you, Professor Ji. It was a very nice 2 talks. Very quickly, on the how do we go about it? My simple ideas. Under the, in any subsection, there is the convener and the subconvener. So they are heading the team. Under that, we have a pyramid arrangement whereby, depending on the number of topics, which may be 1 or maybe 5, there are, sort of senior mature players they are heading it. Under them, they have 2 or 3, trainees or, junior members or somebody like me who wants to contribute to the process from a bottom up. And then every month, that subsection sits down and studies what's the progress. So they keep an interim check on the progress of the work. And that way, eventually, by 2nd month or 3 months, it's getting crystallized. And each subsection then presents to the main clinical development group, the function. I think 9 months is too long because you said yourself 2 to 3 months for emergency, 3 to 6 months for, sort of, interim work, and 9 months for really dementia guidelines for India. That might take 9 months. But, like, paranodopathies, which I am possibly going to be contributing to, or small things. And that will give the entire base of Indian Academy of Neurology the experience to write the guideline. There's no point teaching you. You don't need to learn. You need to teach us how to do all these things. And likewise, there's 10 other people here. And I'm not in favor of importing foreign credits to teach us. I'm sure there are epidemiologists like Dr. Rajeshri is there, and there are so many other people who can incorporate. Yes, we can. You have friends in your who we can tap, touch base, but we should build Indian product made by Indians.
I agree with you. I think at first stage is they should submit some topics and Pico questions.
Yes.
We can have a look at it and then let them start working on. And I agree with Dr. Mishra that I know that if to begin with, let us say 10 groups start or 20 groups start, IN should be happy.
Absolutely.
If even if 5 or 7 of them materialize to publication. So it is good to start in a very ambitious way. But I agree with Dr. Mishra that there will be lack of interest over time, and then some people will drop out, some people will continue to work. Finally, if we find 5, 6, or even 10 see the light of the day, it will be a big success. But that is not to say that people should be discouraged. They should be encouraged to do. And even if something is not like some may be published earlier, some may be published later after revision.
Absolutely.
It is not that all must be published simultaneously like the last time. It can be phased out. So maybe those groups who work very fast, they come up, we can publish earlier. Those groups who linger on, we will publish later. So next time when we meet, we should have questions ready so that people can give comments and decide which topic, which question people are going to work on. At least it should be in our knowledge. And if there are inputs from various people, they can take inputs and finalize what they work on. Then we will meet every month to see.
Yeah, sir. It will be better. It will be better if we have a group meeting again, because there can be some overlapping topics. Like some of these subsections are subject-driven subsections, neuromuscular. So for us, pediatric neurology, it's an age-driven. So if we do something on stroke in children, there will be something which is coming from other stroke subsection. There will be a kind of overlap. So it is better to have a kind of review by the IAN team, the CDG group, before giving a nod for the subsections to go ahead.
Yeah, I agree with you. We should register all the topics and clinical questions, give a green signal before they start working on it. I agree with you.
Okay,
in fact, that's a very relevant point which Vinayan made, because a lot of, like he mentioned, overlaps may happen between different subsections. For example, even in telemedicine, there'll be a general telemedicine we could, but if I have to talk of tele-stroke, they can be part of the stroke guidelines, and they can be combined so that we even don't make them bulkier. They can be part of a major guideline and a sub-guideline of that major guideline.
Kameshwar Prasad, may I suggest you something?
One point that
you request.
So,
something wants to say something, no?
Yeah. So can you share all the presentation with all the members? Number one.
Yes, no problem.
So that they know that if they have missed out on some point, they can go through. Your last presentation was very good. It gives them this. Number two, can we ask all of them, like Parthare suggested, to send that pyramid to us in say next 2 weeks, so that you know that exactly what are the topics they have suggested and who are the people involved. Preferably one person should not be there at two places, so that he is attentive to that particular guideline. So that sort of thing can come to you before the next meeting, so that you can work on that along with Pramod Park. Yeah, Gagan, you can go ahead.
There are two things. One is I will take one younger member to help me out with all the emails which comes, and then collate it, and then we will discuss. So I'm going to make her part of this group and call her for this meeting. Second thing is that some of those, I said, those who are trained in clinical epidemiology, they should be part of this exercise, because they will help probably multiple groups if the time comes. Right? So next time we can call them as well.
Yeah, Rohit, can I couple of points? Hello,
yes,
am I audible?
Yes.
So I think the first thing is I must profusely congratulate Dr. Prasad on an excellent presentation. And I think some of the points that have been raised by others are also extremely important. In particular, one of the things that really struck me, what Dr. Mishra suggested, is that we need to carefully think about the topics. And in terms of that, we have to think of topics which are, there are guidelines, but there are also a void in the available guidelines. And we have to think about the voids which are available, which are there in the available guidelines. So thinking of some novel topics is also extremely important. I was talking to Dr. Meenakshi Sundaram yesterday. So he just suggested, for instance, in movement disorders, what is from our country's perspective, what is the scope of genetic testing in movement disorders? So although there are a number of guidelines for the treatment of Parkinson's disease, there are guidelines for treatment of dystonias and things like that. But in terms of how and what all genetic tests are available in this country and how best we can utilize these genetic tests, so that is something which I thought it really struck me as important. The other thing which Dr. Prasad has said, and I think is extremely important, and is sustainability of the guideline. I mean, this is a wonderful initiative by our president, Professor Nirmal Surya, but we have to also think in terms of sustainability. How are we going to sustain these guidelines? That is something, and Dr. Prasad's suggestion that we have to we can actually stagger the publications as they come by, they are published. So that is an excellent suggestion. And it will, I mean, doing it slowly, my feeling is, it will ensure the kind of methodological rigor which has, the concern about how we do it and the time we spent in doing it. Yeah, I mean, one thing is to do it very quickly and do a large number, but I think it is extremely important that we follow these steps. And in following these steps, I mean, those of us who have been involved in guideline development, in meta-analysis, clearly understand the amount of effort and time it takes, the kind of discussions that go into it. So it has to be a slow and at times it is almost a painstaking process, but it's a wonderful initiative. Thank you, Dr. Prasad, for just this wonderful, stimulating lecture. It is the talk is so many things have been clarified, and I think everyone is really, really charged, and that's to the credit of our president, Dr. Nirmal Surya. So I think just to be summarizing, if I may, and that we need to do it the right way, and doing it the right way will take time. So we need to be aware of that. Thank you so much.
Thank you, Dr. Gagandip. If people think it is going to help, then every month we can have some aspect of guideline methodology, little elaborate, like I talked about grade, but one such day we can talk about systematic review and how to assess systematic review, for example. So yeah, these things will come, and I said I've not covered how this great thing which is if we had every month we can have some guideline methodology which is a discussion across all the groups, not necessarily one group or the other group.
I think it's a wonderful idea.
So Rohit,
Sir, what Sir has covered is
Rohit wants to speak for a long time. Dr. Rohit, maybe.
Yeah. Sir, to me, a couple of things which come out of this discussion are that we're not limiting the guideline from each subsection ideas, and but we will prioritize what we want to do initially. So we are looking for ideas, and we will create the different groups with leads, because the meeting that I had yesterday in the subsection day before yesterday was that that there were points, suggestions made as to these are the important topics, and we thought that each topic can have a lead and a co-lead and members, because they are bigger subsections as was suggested. But I was uncertain whether they'll be filtered out and finally decided by some other group within the IAN, which will decide on the priority areas, or if it is left to the subsection, then we can go by the priority list as to 1, 2, 3, if there is no limit. If there is no limit, and each group can be formed and they can come up with their plan, and that can be, of course, cross-checked about its methodological vigor later by the CDG. I mean the group. So one thing I want to know, sir, is there going to be an internal review committee within the IAN, of course, which is headed by you as the CDG person, but is there going to be another committee which should be the guidelines subcommittees be reporting to periodically? I'm not certain on that as yet.
No, not at all. Not at all.
Okay. And the second thing is that my only concern in this whole guideline framework is that, sir, most of the guidelines in many of the disorders are well published and updated periodically by the Western groups, and in practice, apart from the few nuances that we have limited to our own country specific infrastructure or availability related. The science cannot be changed or not upheld what is available to make a guideline. So my only subtle concern in this whole exercise is that we would label them as Indian Academy of Neurology guidelines, which most publications do, the AAN does, the ESO does, and the other do. But the science more or less remains the same. It's only the tweaking of the way they represent it. So, putting so much effort, I hope that it is going to be really different. I have my apprehensions that it may not be different, but it may be a great exercise to have people learn to develop, which we can update then periodically. That's a bit of my concern.
Dr. Ravi wants to say something. Dr. Ravi has raised hands.
Yeah, I forgot to mention is that Dheeraj, teleneurology or telemedicine needs to be incorporated in almost every guideline, in
That's
the current,
what I was mentioning, yeah.
You probably need to have an element, for instance, what to do in the setting where face-to-face contact is not available. So that needs, what is the guidelines that needs to be incorporated.
But that's an area where there is nothing developed for our country, and that's what I was, in fact, contemplating. And like you did mention, one is a general teleneurology, but if I look at every sub-subject, it will be involved in every subject. So that can be part of the main guideline of that subsection.
Yeah, sir, I have 2-3 small comments.
Yes,
I am really happy that IN has taken this initiative because it will be proving a kind of training also to the people, consultants, and those who have not been involved in this process under the experts like you. And so the second thing is, which I agree that 1 to 2 topics per subsection will be ideal, and that, like if we go over ambitious, that also is will be not very fruitful. Second is, sir, you said that the diagnostics and prognosis related thing has not been covered. For example, in movement disorder subsection, where there is some evidence for DBS and some of the commonly used drugs, that maybe adoption and adaptation will be as usual. But for the India-centric thing, for example, diagnostics, which Dr. Gagandeep also raised, and I discussed with some of the members, where the indiscriminate usage of some of the things go on and what to recommend for general practitioners, so that will be probably more of usage as per if we go by our country. And then prognosis wise, if we overlap with some of the subsections, like we may have to work together with geriatrics, we may have to work together with those for regarding the long-term prognosis, how to explain so that part also, sir, in future, if you take monthly some of the guidelines, some topics, like you said, you can cover regarding how to use the diagnostic and prognostic related issues.
We can do that. So yes, if it is, I'm not completely banning diagnostic or prognostic things. People can set their own priorities.
Right.
And what Dr. Rohit was asking, whether there is any clearance group. No clearance is required. Each subgroup or each subsection has to do on their own, but they have to just inform or send a list of what they are doing or going to do, so that if there is overlap, we can warn people that, look here, this group is doing this, you better join hands rather than doing it separately. So duplication can be avoided if there is a central place where what people are doing is you can say informed rather than screened, informed. So you have to just inform what each group is doing. But what I'm saying is, now that we have had discussion, you go back and discuss and identify priority topics.
Right.
It may be diagnostic, it may be prognostic, it may be intervention. But as I said, that priority for intervention comes because that is, as you know, that is sometimes overused or underused or not used, or all kinds of uses are seen across the country. So where you think there is there is variation in practice, where there is controversy, whether there is lack of recommendation, that is where you should prioritize. But if diagnostic is priority for a group, there is no ban on that. We can, there is a lot of work has already gone on systematic review of diagnostic tests, and lot of work is being done for grade on the diagnostic test. So we can certainly take it up some other day. And if there are no more comments, then
I have one.
Yes.
Sir, I would like to thank you for a wonderful nutshell things, which normally it takes in any systematic review workshops, what is covered in 3-4 days, you have covered it in 2 hours. And what my request is, most of the subgroup people may not be familiar with the meta-analysis or systematic reviews at all. So what I would request is, if the subgroup requests you to, when they have their own meeting and they can approach you for some guidelines, we will have some meeting with you, so that during when they do the review, you can give small group meetings which will be to the concern, which will be more specific to the subspecialty. We will be requesting your assistance, sir.
No problem. If I can assist, I'm always there. Just keep in mind that at present I have a busy assignment. So
yeah, I know, sir. I know. We know what is the position you are holding. But we will not be wasting your time. We will ensure that we respect your time, and we ensure that such meetings wouldn't cost you more than 20 to 30 minutes, sir.
Wherever I can help, I will help. No problem.
Thank you, sir.
That way, I think that monthly meeting will really clear a lot of things into the streamline. And I feel that the moment you will start working, you will find your own difficulties, and every month if you discuss, it will give more and more way and clarity. I think, Dr. Prasad, you have done a wonderful job, and I think it's a great initiation. And I only hope that the spirit which has come is been maintained for next 1 year. Thank you very much.
Thank you very much.
Thank you. Thank you. Thank you.
Thanks a lot. Dr. Pramod, you wanted to say something, Dr. Pramod? You are muted. You are muted.
Sorry. So just one thing that, certain guidelines are also always, or sometimes the nation-specific guidelines or country-specific guidelines is also based on supposedly investigations, genetics, etc., on the practice parameters of all the, say, neurologists, how they are doing it in the country. And before framing a guideline, often many countries have done a national survey, a scientific survey from its members. And that also can influence, forming a guideline at the national level. So this also the IN can take up, or the several subsections can take up. So recently we did a international rare movement disorders guidelines on how the genetic testing should be done. A survey was done. After that, based on that, the survey, the guidelines were formed. So these type of approach also can be taken up in the future.
No, these are the types of activities IN should be doing, actually, isn't it? And it's good that it's going to happen. I'm sure a lot of activity will come out as a follow-up of this guideline development process, which is welcome. So thank you very much for your kind attention. And we thank the President for taking this initiative. Thank Dr. Gagandeep for steering it as Vice President. And thanks a lot. Thanks a lot.
Sir, and can some of the relevant literature be shared along with the presentations?
Yeah, I will share the presentation. I will send it to Bhavesh, and he will send it to everybody. You can send to all the members. How does it matter whether they read?
Sir, and the relevant literature, maybe some of the papers that you mentioned on the recent Agri or the other guidelines.
Okay, right. I will do that.
Thank you, sir.
Not in one mail, in 2-3 mails, huh? Right?
Yeah.
Okay, thank you.
You can send to Bhavesh, he will forward it to everybody, and then they can subsequently send it to all their members.
Yeah, send it to all the members. Maybe some youngster will get initiated and join the development group of the subsection, right?
True.
Okay.
Thank you, sir.
Thank you.
Thank you.
All right, sir. Thank you.
Have a nice Sunday, everybody. Thank you very much.
Yes, sir. The leftover one.
Asmita, you can end the meeting. Hello, Asmita.
Yes, ma'am.
Yes, you